So welcome to the show.
Thanks for having me. It's great to be a part of your show. I've been a big fan of it. I watched a few of your episodes and they're all great.
Awesome. Well, I've become a big fan of yours. If anyone paid attention to Friday's masterclass through Act U, you had a brilliant, simplistic way of going through a complex matter such as TMD and occlusion, and really recognizing a lot of the diagnostic principles behind coming up with what the proper way to look at something case-wise, and then from there figure out the treatment plan of action. So I really, that's my love language in dentistry now. I really love that type of lecture, and it's something that was really resonating to me. And I was listening to the recording while I was at Costco, just like forgetting what I was shopping for because I was just so glued into what you were saying. And I had so many notes. So we'll run through that later on, but I really would like to just kind of highlight you first in terms of your early career and what happened. So I guess the first thing I would say is, how and why did you get into dentistry?
Well, that's a very interesting question, because my original passion, at least starting at Clemson University, was chemical engineering.
Sure.
That's what I actually got a degree in. I was in chemical engineering, which is not the smartest way to go to dental school.
Okay.
And my path to dental school is a little unusual because, and I don't know if you heard a little bit of my story when Kurt interviewed me, but my parents actually had me at 16 years old.
Sure.
And, lived in a little single wide trailer most of my life, was fortunate enough to have a grandfather that kind of guided me and encouraged me to, just achieve greater things. And that really led towards me getting into Clemson. And then during I guess it was my end of my sophomore, beginning of my junior year at Clemson, I went to a dental appointment for the first time ever. I'd never been to a dentist before.
Ever.
Heck, I should probably go.
Yeah.
So I went in to see him as a local dentist in the Clemson area. And I said, you know what, this is pretty neat stuff. And I started talking to him and said, you mind if I come by and shadow you and just kind of see what's going on? And he said, no problem. Just come anytime you want. Well, that was a mistake for him because I was over there all the time.
Just addicted to it.
They got to where they trained me into doing sterilization. I was assisting. Before you knew it, I was doing everything. And so I developed a passion for dentistry at that point and said, this is something I really want to pursue. And since I was already a chemical engineering major, I had a lot of the prereqs, so I just had to make up a few things. Started pursuing that path to get into dental school, and fortunate enough to get into MUSC in Charleston, which was a
great school.
Awesome place to go to dental school too.
Yeah, my sister went to college in Charleston, so it's such a great place.
It is. It's a great place. Live right on Wentworth Street. We happened to find a place that they only rent 2 dentists. So my roommate and I had just an awesome place right downtown. And another little funny story is we took some of my loan money, and another classmate friend of mine, we went out and bought a boat with some of my loan money. We put our money together. And so we spent a lot of time fishing while we were going to dental school too. So we had a great time with that. So beautiful place. And during that process of dental school, I just started developing a lot of questions about how things worked. And part of the engineering background was just trying to see how this whole mechanical system worked.
Definitely.
A lot of questions. I had a great mentor in the pros department, Jimmy Rivers, and he was really instrumental and encouraging. And he actually gave me Pete's book, and the old red book at the time. He gave me Pete's book and said, here, read this, because I was driving him nuts, asking him questions all the time.
Sure.
And that just made it worse, because now I just had more questions.
Asking more.
Yeah, I read the book and it's like nothing but more questions. So then started, they encouraged me to start looking into a residency program, which was down at the University of Florida in St. Petersburg. They had
Great
a connection.
program.
Yep. So I applied for that, got into that, and once I got there, a very interesting thing happened to me. And everybody has a Pete story. Just about everybody has a Pete story.
Sure.
And so my Pete story is when I went down to St. Petersburg they take there's only 4 residents at the time, but those 4 residents go into seminar 1. That's the first thing they do. They get to go to seminar 1 and seminar 2, and that's about it. And so at the end of, or halfway through seminar 1, I had met Ann Dawson. She was selling some of his books and different things, and she had heard from someone that I was a young dentist just wanting to learn from her dad. I'd already read his book, had all these notes in his book that I was asking her about, because I didn't think I could approach Pete, so I had all these notes, and she goes, just hang on, because I was driving her crazy with questions. So at one of the breaks, Pete came up to me, and Ann introduced me to Pete, and he goes, hey, I'm Pete Dawson, and he was just so kind and generous with his time. And he said, I'll tell you what I'd like to do. If you really want to learn this stuff, I'm going to take you through every single class that I teach in 1 year. I'll take you through every hands-on class, every lecture, everything. I'm going to take you through every one in 1 year. And when you go to do your cases, when you go to work on your cases, I want you to bring them over to my office, and you and I are going to work on those cases together.
Wow.
So that was my introduction into dentistry. I mean, I was like, I didn't even know what I was getting at the time.
What a gift. Yeah, right.
And so here I am working on a case, and Pete's right beside me, and we're waxing the case up together. And typical Pete, and I think I heard some of the other interviews with some of the other, he was notorious for never answering your questions. He'd always just ask you another question.
Sure.
You kind of figured it out. And so
you ask a lot of questions, and then he's asking questions. You guys aren't coming up with anything.
But he could tell I was a very slow learner, so he needed to take a lot of patience with me. So I actually probably sat through seminar 1 about 4 times that year, just because every time you sit through it, you learn something.
Oh, something new for sure.
There's always something new. Like you and I both know, every time we hear a lecture on occlusion, and we'll pick up another pearl or something different we just didn't know or hear, or see it in a different way. So anyway, it gave me a thirst for knowledge. He was very much of an encourager. Right after, at the end of that residency, he offered, for me to stay in St. Pete, but I was going back to the Greenville area where I was from. And he said, let's just see what's going to happen, because you're going to go back to the world, and I'm going to send you out in the world and to see what happens with this training. And so that led to, a practice. I started from scratch, and just started a practice from scratch.
That's your hometown?
It was sort of near my hometown. It's probably about 30 minutes away from my hometown, so it's fairly close. And so we.
What was your motive behind a startup versus acquiring a practice?
Well, good question. I looked at several practices to purchase, and once I had the curse of knowledge at that point. So then I'm sitting in a practice, and I worked for a few dentists for a little while, not very long, for a few months at a time. I practiced in particular in the area where I was going to he's a fantastic guy. Patients loved him, really good person. And I would say, so where's your articulator at? There wasn't one in the building, it's like, I'm like, so you're doing a 6-unit thing here, and it's not
you don't need that, right?
So it was difficult for me to buy. I said, so what am I actually purchasing? You're purchasing the goodwill of these patients, and you're purchasing a bunch of old equipment at the time. So I said, why not just start my own deal and just pray for patients, and that's what I ended up doing. I was fortunate to land in an area that was growing a lot. It was a rural area, but it was growing. And so that kind of got my journey going right there.
Do you feel like there's a difference between you starting up an office at that point in your career versus someone who is interested in starting up an office now?
That's another great question. I think, Yes, it's different because of the technology and stuff that's different now. I think the fundamentals of starting a new practice haven't really changed.
In what
And
way?
yeah, what I mean by that is like one thing you had asked, you had written down before about a mission. What was your mission when you
Sure.
started? So my mission, and I looked it up, and I was just making sure I was accurate. I put improve the lives. I put improve patients' lives with continued dental excellence. That was it. So I wanted to improve patients' lives with continued dental excellence. And because everybody's definition of excellence could be different.
Mm-hmm.
So my definition of excellence could be different than yours, or it could be different from somebody else. So, and I wanted to put continued dental excellence because we never achieve
That's
dental
so
excellence.
good.
You know what I mean? We never arrive. We go, oh, we've got it, and even, the Frank Spears and John Costa, and the Pete Dawsons would be the first people to tell you that we have not arrived yet. There is so much more to learn.
Sure.
And so that's the beautiful thing about dentistry, is there's always something new to learn, which is great. And so I really had a vision for wanting to, improve patients' lives with continued dental excellence. And through that process, part of my vision was simply to do it with integrity and compassion. And so that was kind of the gist of what I wanted to do. And so when I started my first year, I was just praying for patients. Heck, you're happy to see anybody, anytime,
Sure.
doesn't matter what. I was cleaning my own teeth, which is really, really scary. Crazy scary. And so believe me, you don't want that to happen. So
Never.
I did that for maybe 6 or 7 months until I was busy enough to where I could hire a hygienist and kind of get going. But what I mean by starting a practice now, a young dentist that wants to start a practice now, if they really want to make sure that they're focused on dental excellence, and whatever that dental excellence is, to always strive for better, because all of us are at different places in our career. So always trying to do better and, serve those patients with integrity and compassion. I think those things, those principles never change.
Never.
So yeah. So if you want to, if you wanted to start, if I was starting out right now, I would not be afraid of starting out from scratch. And I know we're different because we got corporate dental that was not really around 21 years ago when I started. So corporate dental, but you think about it, heck, if corporate dental can open up a place in nowhere with you know what I mean, that then we can. The one thing that I will say now is I feel like younger dentists have some advantage in the fact they know there's more knowledge out there about how to run a practice. If they're willing to go and find that knowledge, there's more knowledge out there. Like you went to Act Dental and they helped you kind of get, that knowledge is there if you just go and find it.
No doubt.
Yeah.
The only thing I would say is maybe with the number of insurance plans and things like that might be a little bit more difficult, as well as acquiring patients was probably a different process with your opening versus now with a lot of the SEO and website development. And it's very expensive to acquire patients online now to get on the top of Google rankings and all that. So that would be the only things I would ever maybe rebuttal. But you're right. If you have a solid treatment of people in the right way and take good care of them with integrity and continued excellence, everything's going to fall into place. It's just a matter of how quickly, the practice will build from there.
And we'll build on that thought and I know maybe a little bit later we talk about new patient exams, things that we can do to enhance the experience for these new patients who are coming in.
Sure.
We can talk a little bit about that later, I guess.
That's a great thing. So now you did Dawson Academy after your residency then too, or did you?
I did the entire Dawson Academy that 1 year.
Okay.
Every class, every program in that 1 year. Then I went on to Pankey, and I did Pankey after that.
Right.
Then I went to Spear and started doing Spears courses after that. I was just a junkie. I was just one of those.
Seems like it. So
yeah. So I just wanted to get knowledge, and I heard John Coyce every time I could hear him speak. I mean, there's just so many really sharp, wonderful people who have taught me I mean, so much over the years, but that was kind of my path. And I think the challenge for these young dads now, they go, you know what, I can't afford to go to Spear or Coist or something, you know, but the knowledge, there's so much free knowledge out there. If
Tons.
you really want to go get it, you know, I mean, heck, this is free, isn't it? I mean, it's what they're, yeah, I mean, they can get it if they want to go after it.
I think the hard part with a lot of things is there's just so much fragmentation of the education. And the nice thing with the curriculum base is you do get a foundational understanding of something. And then from there, you can go to different modalities of koi, spear, panky, whatever you did, but you built upon a really solid foundation. That's what John Cranham was talking about a few weeks back. He said, I would just pick one and go with it. They're all great. But then after that, build on top of things, and figure out what is your way of doing things as opposed to, go down that avenue. So I love that. That's great. Now it's something that I perceive that you're a big family man. Is that, I mean, I would imagine that's the case with 3 kids and all that, but I think balance of time is a really important component of being a family man. And is there something that you've done that you found with your practice and your education that you did in order to implement that in your life?
Well, Pete used to call it blue time.
Sure.
He had his little thing that he called it. And I would just, early on, I wanted to make a decision to spend time with the family. So I started, I only worked Fridays probably the first maybe 3 or 4 years I practiced. And after that, I quit Fridays and I started doing Monday through Thursday. And then after about 10 years, I went to 3.5 days a week. So for about 12 years now, I've been 3.5 days a week. And some people would say, well, that cost you money, and it does, I guess. You could say, well, hey, it cost me money, but it's also gaining time with my family. I mean, I love that experience. It's worth way more than any money. Those memories with the kids and little quick vacations on a short, a long weekend, those kind of things. We've got the, I used to say this is I say this a lot in my lectures. I'll say, I can teach you how to fix teeth. I can teach you how to make things look beautiful. I can teach you how to do occlusion well, all those things. But remember this, all the teeth that you fix will one day be in a box, but the lives that you impact will last for generations. So
that's a statement right there. That's good.
Right. So, I mean, and really and truly, we get so focused on fixing the teeth and we forget about the people around us.
Sure. Now, are you talking about patients? Are you talking about the team that works around you, your family? What, I mean, is everything.
Everything.
Yeah, that's so good. I'm going to steal that line. That's a great thing.
They're all family. I mean, I look back at some of the crazy, cool things, how we've impacted our team members. Mm-hmm. In a positive way or whatever, Sure. I remember one time my team member had something wrong with her car and she was my assistant at the time. She didn't have the money to fix it. And I mean, I grew up fixing things like cars and stuff. So I had a Friday off. I said, I'll go to the house. And I fixed her car. Something wrong with her wheel, or I don't remember exactly what it was then. But I spent half a day fixing her car when I could have been in the office. But that little bit of time meant more to her than it was crazy the impact it had.
I know.
So yeah, all of it, because we're all family. I mean, our family. When we get to our office, that's our family. We get home, that's our family. All of it. So,
I love that. Yeah. I really, really love that. It's not about the teeth that are going to end up in a box one day.
They will.
Oh, good. I mean, there's just so much to that, right? And I think to piggyback off of your balance of time and ACT made me cut 50 days out of my work year. And what might be surprising is that actually financially, for some reason, magic, you don't lose any money. You actually might make a little bit more, which is crazy because you still do the same amount of dentistry. Just you find more ways to be efficient. And then you have 50 more days that you can do whatever you want with. Be with your family, be with your CE, whatever you want to do in terms of what you find valuable in your life. And I think right now, especially with COVID, I would imagine your office is pretty busy too, but we need those days off, and those times away where you can just unwind and relax and get back to the office refreshed as opposed to being on this hamster wheel of life that's just constantly in motion. So
Well, and you brought up an excellent point that I failed to mention is that the fact when I did drop those days and those times, profit margin didn't go down, it went up. And I'm
sure,
making more money.
weird,
It
right?
doesn't
Doesn't make
make
any
any
sense.
sense.
I don't get the math either, but whatever.
It's
So
cool.
you
Yeah.
can achieve it. I think that's the hard part is I see a lot of people that are getting out of school that feel like they have to work 6 days a week
Yeah.
and just hustle and hustle and hustle. And you can also change your hours, which is a thing of beauty too. I know Kirk always promotes the 7 to 3, and we did 7 to 2s, 9 to 3s most days, and you can get home and be with your family and enjoy the afternoon and evenings,
Yeah.
which is a thing of beauty. So I love all that. So let's segue here. We have a good amount of time. I really want to dissect what you did on Friday. So if you're listening out there, Bo did a wonderful job in his presentation on Friday. And it was a master class. And if you don't have access to Act U, every Friday we always have some type of master speaker on there. And from there, it's a different topic. There's Bob Margis, Mark Hyman, Bo is on there, all talking about different things. If you don't have access to it, email me, kevingroth@gmail.com. I'll get you access so that you can watch this. But I was riveted by that presentation because I just really am an occlusal junkie as well. So for me, I had so many takeaways, especially trying to reference it from a young dentist aspect of things. But I think the first thing I would talk about is just kind of how you look at something from the three different modalities, right? So you have the teeth, you have the joint, you have the muscles, and how they all need to be kind of in harmony. So can you break that down a little bit in terms of what we normally look at, what everyone kind of should be looking at?
Right. Well, and this information, I feel every young dentist should try to master.
Absolutely.
It's key fundamental information that beyond doing a full mouth rehab, you've got to master occlusion and understand what's happening in the joint space. I feel too many times a lot of young dentists will want to go take a course to learn how to do a full mouth rehab, and they skip this part. The
Yes.
most important fundamental part of it, what you've got to do and understanding what's going on in the joints. So to touch on what you're saying about joints, muscles, teeth, and that also plays on the fact, remember, there's only 3 ways to build an occlusion, and that's either using the patient's existing bite, MICO, using a muscle-based bite, or using a joint-based bite, and that's it. That's the only 3 ways to build an occlusion anywhere on any of your patients. So, but that is also the perfect world I want to create where I have the joints fully seated, all the teeth to come together at the same time. When the joints are fully seated, muscles are happy. That is the perfect world I'm trying to create.
Yeah, you can't say that any better, right? I mean, that's the trifecta right there that you need to achieve.
Yeah.
I, I can't encourage enough people to watch your presentation. I mean, that to me, if you're a new grad, if you're in dental school right now, you got to go back and watch this 2-hour video, and just redo it over and over and over again, because it's so much wealth of knowledge that would save so much trouble if you just mastered that and got a firm understanding of that prior to doing anything with a burr. Because once you start prepping and once you start doing all this, that's going to get all muddled. But if you actually understand the diagnostics behind it and understand what is going on within that patient, it does, the rest of it kind of fills in the blanks there, right? But I don't know if you could just emphasize the trifecta one more time, because I think it's so important, is that you got to get the joint right, and then everything else falls into place.
Yeah. You can't understand how to develop or create great occlusion unless you understand the joints and what's happening in the joint space, because the joints dictate where the teeth come, how the teeth come together. So if we fail to understand what's going on in their joint spaces, we're never going to get the occlusion right. We're always going to be guessing. We're always going to have unpredictability. It's
Right.
just, I mean, that was one of the major gifts that Pete gave me really early on, is understanding that part. And that was the building block behind how successful my practice has been over the years. I've been very fortunate and blessed to have a very productive practice. I don't see many new patients. I see maybe 12 or maybe 15 new patients a month.
That's all you need.
I mean, that's it.
Yeah, that's all you need.
And I wouldn't know what to do with 25 or 30 new patients.
No,
So anyway, yeah, that's a really important thing for these young dentists. And I do have a handout with that master's class as well, which kind of goes through everything. They
Yeah,
come
it's
up with a
great.
handout. And it touched on, we didn't have time to go into Piper's classification and stuff like that, but that may be for another class. But it at least gives some of your students the fundamentals of how this joint works. It's a good start.
It is. And one more thing I'd like to piggyback before we bring Bill in here, is that I think a lot of people think that if they're doing some type of um, occlusal diagnostic component, they're doing a full mouth reconstruction. And you really put a mark on that by saying the woman with the second molar interference, because that is a thing that we see all the time in dentistry. And if you just knew something about how the joint works, how the muscles are in conjunction with that, and how the teeth play a role in it, that could save a lot of people headaches right out of school, and 10 years out, 20 years out, whatever it may be. But I thought that was probably the second most profound thing you said, which we'll get to the first thing in a little bit.
Second molars, without a doubt, is one of the most difficult teeth to do in dentistry. And if it's in occlusion, for sure. And so to take a second molar and actually drop it in the mouth and not have to pick up a handpiece and adjust it is phenomenal. You know, if you can do that, then your dentistry is going to be predictable, because you think about what happens now. I showed photos of where dentists had ground down to the metal on these patients. Well, you don't see the metal anymore, because we went from the best possible restorative material ever created in dentistry on second molars, which is gold, by and out, literature-based, the best restorative material we could ever put as a crown material in the second molar area. We went from that, which is soft, to zirconia, which is hard. So now more than ever, your occlusion better be perfect, or you're going to have a lot of people with that open contact between the first and second molar. Now they're going to be packing food in there. It's going to drive them crazy.
Sure.
So a lot of your listeners are going to relate to that.
Yeah, I think so many people do. And ultimately, if you knew that if the joint needed to be seated in the right position, you know, at that point in time, that's where the interference lies, because the joint's trying to get to that space and something's in the way. And ultimately that tooth is going to give out. And that's why they get that tenderness, that ache, whatever it may be. And I think it's just so profound, especially with the material selection, like you're talking about. It just, I don't know. If you haven't had those moments, you haven't been practicing long enough, right? I mean, ultimately that's what it comes to.
It takes 5 years just to figure out what you don't know.
Exactly. Right? I'm only 7 years out and I still don't know a whole lot of stuff.
But 20 plus years and I still am trying to figure it all out.
Sure. So I just think that's just, so when we're talking about doing some type of occlusal analysis or case development, it doesn't have to be full mouth. You know, it really is just understanding the recognition of how the teeth come together, and it could be a single unit. And once you understand that, that makes a huge difference. And like you talked about in that presentation, is by solving that woman's issue, you end up getting a comprehensive case out of it. It's just a matter of doing what was best for the person at the time and gaining that trust. And then that led to something that was obviously life-changing for her later on with her experience through dentistry. So I love it. Let's take a little break here. I'm going to introduce my unofficial co-host, Dr. Bill Robbins. How are you doing tonight?
Hey, Bo. Hey, Kevin. How's everybody?
Good to see you.
I've actually been here most of the time. I didn't get a link tonight, and so I was piddling around with Caroline trying to get a link. And then I'm going to go get a COVID test tomorrow, and so I had to do an online little thing with the clinic, and so that's where I've been doing that.
You okay? Everything all right?
Oh, yeah, I'm good. I'm just, I haven't been tested yet, and I've decided it's time. I feel like I should, and so I'm going to go do it tomorrow.
Yeah, I think the hard part right now, as we're discovering, is that what happens when someone gets a cold? You know, are we going to take 2 weeks off to make sure that we don't have COVID? That's a really tricky topic, I think, in our day and age right now, is you can't decipher between what would be COVID and what would be a cold. And we know cold and flu season's coming. I mean, at least in Michigan, I don't know about you guys down south, but I don't know. It's kind of a tricky thing right now.
Oh, yeah. The ethics of this whole thing is going to become more and more complicated.
Yeah.
For sure. When the life of your practice butts up against your ethical values, it's pretty difficult sometimes.
Yeah.
Ultimately, you try and do what's best. You see,
Do the right thing.
and do the right thing, and that's all we can do, right? So, and we'll all get through it. But I'm hopeful that cold and flu season doesn't bring too many of these situations where we're going to be, or people traveling. I know there's a lot of states that have the mandate that you have to quarantine for 2 weeks, but do you restrict the quarantine travel? I mean, it's just, these are whole things that we're dealing with right now that I think are pretty tough. But
I was reading somewhere that where the cold season is already going, all of the social distancing and masks has had a giant positive impact on colds. In other words, we may not have as bad a cold and flu season because we're going to be so much more serious about our hygiene. So I hope that's the case.
I do too. I mean, how many times have you had a patient be like, I'm sick, but it should be fine. Just do the work on me. Like, there's no way we're going to have those situations in our office going forward, right?
Done.
My only rebuttal of that, Bill, would be, because we're so sterile right now and sanitizing everything, is maybe our immunity might be a little bit on the weaker side of things. I don't know.
Yeah,
So
I think you can just take care of that by eating some dirt.
there you go, right? So it's all
Go
kinds
outside and walk barefooted and eat a little dirt, and you'll be fine.
That's it, right? That's the Texas way. So, well, let's get back to our chat here. So, Bill, we've been talking kind of about occlusion and all these different components, which I'm sure you're quite fond of that. But I also love the clicking joint discussion you brought up, Bo. And I have heard so many times dentists talk to patients about, oh, yeah, you have a click and pop there, but you don't have any pain, right? No, I don't have pain. Okay, so you're good, right? So, but you kind of disproved a lot of that during your discussion. So I'd love you to highlight some of those things in terms of, because as a new dentist, I thought the same thing, like clicking and popping, you're fine, it's just normal. And it isn't.
Well, what I would like to say about that is anytime a joint clicks or pops or used to click or anything like that, there is damage in that joint. It is not 100% healthy, even if it has no symptoms whatsoever. So I document that in the patient's chart. You're going to have 50% of your patients don't even know they have a clicking joint.
Sure.
But that during the new patient examining process, you're going to discover they do. And it's really important that not only do you discover it, that you actually note it and document it well, whether they're symptomatic or not. Because here's an example of something that possibly could happen. So let's say you've got a patient that, I'll give you two examples. You got a patient that wasn't aware of a clicking joint. You go and you do a single unit crown or even a quadrant of composites on them. And you do it successfully. They're happy with the crown, they're happy with the fillings or whatever. But a week or two later, they realize they've got a click in their joint. And they come back, well, I didn't have this click before you worked on my tooth, before you did this crown. And they could have had it all along, but if we fail to look at that during our new patient examination process, then that could come back to bite us.
Absolutely.
So that's one example of where you can really get in trouble. I've got another example on a different case I could show some time, but this is a gentleman that came in to see me, and he had a clicking joint on his left side. He had one that used to click on his right side. So by definition, he was a Piper 3A on one side and a Piper 3B on the other. That just means the lateral part of the disc was stuck forward on one side and it was clicking on the other side. So that's the scenario. So, and he needed major reconstructive work. So and his clicking or his lack of clicking on that one side had went away a few months before. Like it had been clicking and then it just went away. So he had made me aware of this. In the new patient examination process, I documented it. We were completely aware of it. So this was an acute lock, meaning it had not been locked that long. And so if you think about what's holding that disc in that forward position, that hyperactivity of that superior belly of lateral pterygoid is holding it there. Well, when I restored him, and I made him aware of this too, I said, when I restore your mouth and I develop your occlusion and get things more stable, there's a good chance that that muscle that's holding that disc in the forward position may release, and guess what? Your clicking comes back. Now, I call it the hero zero rule. If you tell them ahead of time you're a hero, you tell them after the fact you're a zero. So it's the hero zero rule here. And So I made him aware ahead of the time that there's a good chance his click will come back, and that's a good thing, not a bad thing. And so, and it did actually come back on that one side. So I looked like a hero. But even if it wouldn't have come back, if it still would have stayed locked, that's okay. I still made him aware of the possibility.
Sure.
So there's just a little minor examples of how we should be looking and evaluating these joints on every new patient. I even document range of movement on every new patient.
So important.
I mean, if you don't measure it, you can't improve it. So, or you can't at least monitor it.
It is I mean, I don't want to simplify anything that's so complex, but to take these measurements, to take these understandings of why it's clicking or when it's clicking, it really tells most of the story for you. So then once you start doing all your diagnostics and your treatment plan, you can really discover, okay, this is why it's happening, right? So, I mean, if you're having that lateral pterygoid that's tight, is that a posterior interference on that side? Or like you said in your presentation, they have this clicking and popping, and it probably is not going to go away because the posterior ligament is stretched out.
Yeah.
And ultimately, you can tell them, I can try and improve it, but I just I can't guarantee that because you've already done damage to the joint, right? But also, like you talked about in your presentation, is the rotational element of things when you get the click and pop, or is it a translation when you get the click and pop, and what the difference is between that? And if you don't know what I'm talking about, please go watch his presentation because it's so perfectly summed up. And we don't have time to get into it, but at the same point, I think you have the diagrams to really support it. And it was so confusing to me, the whole rotation versus translation element of the joint. But it's once you really understand it, it really makes things a lot easier to treat and plan and understand what's going on with them. So.
And the beautiful thing about it is 98, 99% of these patients with quote DMD problems coming into our practice are very treatable.
Yes.
With complete predictability.
Mm-hmm.
You look out for that 1 or 2%, and that you can treat them as well, but you just have to treat them a little differently.
Sure.
But, so.
Can we highlight those red flags? I don't know. I don't putting you in the spot here, but I think it's something that was important too. And I've learned that lesson through people that have told me about these red flags. And I think it makes a huge difference to know when to proceed with caution or when you feel like you can comfortably go forward.
Right. Well, we can go through some of them. I mean, if you want to, we can touch base.
There's a couple that are really
profound. I mean, for example, here's a key one. If you put a deprogrammer can work fabulous.
Let's describe what a deprogrammer is, though, because I didn't understand that for a couple of years. I heard the term, but I didn't understand it.
It's simply a device that's going to separate the posterior teeth, and only the anterior teeth are going to touch. So normally I will make a device that snaps in the roof of the mouth, and it will be a small device so where the lower anterior teeth just rest against a little platform on the back side of the roof of the mouth. So
is this Hawley retainer that you have a little ramp on? Is that?
Yeah. Yeah. So I just have a laboratory make it. It looks very similar to a Coist deprogrammer, if you ever seen one of those, but it doesn't have a labial bow. But I mean, it's all the same concept. But it's simply you're getting the back teeth out of the way, and patients do fabulous with them. They do really great with them, and they only wear them at night, not 24/7. So
why would they do so well with those?
Because think about it, you're actually getting what was in the way out of the way. And the best way to summarize what I say about splints is any splint works if it'll trick the brain into thinking the bite is perfect, then the splint will work. Sure. If you can trick the patient's brain into thinking their bite is perfect, the splint will work. If it doesn't trick the brain into thinking the bite is perfect, it won't work. So that's what essentially a deprogrammer does. We talked about the inverted tripod. It creates a third leg to the stool, which allows the back teeth to get out of the way, allows the condyles to seat, and it works fabulous. So if you're using a deprogrammer and a patient and they get worse, don't tell them to suffer and just ride it out. Tell them to take it out and don't use it again, because they may be in that 1% category where they're off the medial part of the disc 100%, and now they're in retrodistal tissue. And until that retrodistal tissue scars over and forms a pseudodisc, it's going to be painful for them. So that's a good red flag to remember. Is say if I put a patient in a deprogrammer and they get worse, that's a big red flag.
If I had a highlighter right now, I'd highlight that statement right there because, I mean, Bill, you've talked about this a couple times now. You can make people worse by putting them in an anterior deprogrammer. And ultimately, it makes a huge difference in terms of understanding what's going on with them. In a splint like that actually is very diagnostic. And also, I mean, in theory, you can have a Lucia jig be an anterior deprogrammer. You can have, I guess, a leaf gauge, right? I mean, all these different modalities are ways of having something because you're separating the back teeth. A quick splint, an NTI, they all kind of do the same thing. But I think it's so important to understand that, okay, is this helping or is this making things worse? And I don't know. We'll get onto that in a little bit, but
I can give you a couple more red flags just for your listeners. Okay. One being significant deviation when they open. So look at jaw movement can tell you a ton about what's going on in that joint space.
Mm-hmm.
So significant deviation to one side with very limited opening. It might be a possibility. So those are the other thing is if somebody's got wear on anterior teeth and they cannot make them touch. So let's say somebody's got an anterior open bite and they have wear where they used to touch, but now they can't make them touch. That's a red flag for me.
It's not sucking on lemons or anything like that.
What's that?
It's not sucking on lemons or anything like that, right?
Right. It's not sucking on lemons. It's not. You don't get the wear process from sucking on lemons. So, and if it was an airway problem or if it was a tongue thrust problem, you would have mammalions on those teeth. You would not have wear facets. So those are a few little things that you can look at. Facial asymmetry, those kind of things. Just a few of the red flags.
And why would the jaw deviate to one side?
Lack of translational movement on that one side. So
because
so the disc is stuck in front of the condyle, which is restricting the translational movement on that one side, causing the patient to deviate. So there's not many rules that we follow, but a general guide is whichever side they deviate to the most is the more damaged side.
Mm-hmm.
So,
and you also might have patients that maybe deviate but come back to center.
Absolutely. And you think what's happening with that. So let's say somebody deviates to the right and then they straighten up. Well, what happened is they click back on the disc and then they straighten up. And then you see them go back and they do this. You see, so you have this little weird S movement, and that's clicking on the disc, straightening up, popping back off the disc, coming back. So,
sure. It all comes back to knowing anatomy. It all comes back to knowing how the joint works, the muscles involved with these different. Yeah. I can't emphasize again to just go back and watch your presentation or get into a core curriculum of some sort and learn this stuff. And if you can, you should be able to memorize a diagram and draw it out, because if you could do that, you've won the battle. You know, I think that's certainly something that's important. So the other splint that you would use if you did have somebody which had an anterior deprogrammer and they felt, you know, something going on would be a flat plane splint, right? And can you describe that?
Well, that is a flat plane splint with no canine guidance.
And why would there be no canine guidance?
What's that? I'm sorry.
Why would there be no canine guidance with that?
Well, the reason there would be no canine guidance is because if you were to give that patient canine guidance, you would actually have a situation where they could guide out on that canine, that guidance of a canine, and squeeze on it and essentially create a deprogrammer. You see, so it's creating a deprogramming problem by giving them canine guidance. And I can't take credit for this knowledge because Jim McKee and Mark Piper taught me this years ago. And we discovered, and I've been doing this for many, many years, but we discovered early on, and we all kind of learned about the same time, but they taught me. And basically what happens is these patients who are completely off the disc and now they're on retrodistal tissue, and you're trying to form a pseudo disc. For years, we would put them in a flat plane splint with canine guidance, and they would eventually form a pseudo disc, but it would be a slower process. I mean, it would maybe take a year, And it didn't always just be a smooth process like we were hoping it would be. Once we took away the canine guidance and allowed them just to skate around like an ice skating ring, they formed a pseudodisc much faster. And so patients got better quicker. Some old studies actually demonstrate this very well. A lot of times when I'm lecturing, I quote a study by Smith, and it's a 1986 study, the numerical model of TMJ loading. And it actually talks about the loading of the TMJ space with, if you were to give a patient with that canine guidance or a deprogrammer, either one, and they squeeze on the deprogrammer or they squeeze on a splint with canine guidance, you can put 60% of that bite force into the joint space. 60% of the bite force can load into the joint space, which if you're still on the medial part of the disc is not a problem. Okay, sure. That's fine. But if you're off the medial part of the disc and now you're loading in the retrodistal tissue, that's a big problem. So once you take away those canine guidance, once you take away the canine guidance, that load goes from 60% to 5%. Major, major difference. So these patients get better a lot faster when you put them in a flat plane splint with no canine guidance. And the only time I do that is a patient who is in that 1% category. Those are the ones I use it on.
I learned so much there. That was great. You know, that's something that
that might have been more information than you wanted. So I'm sorry.
No, I love that. That was really beneficial for me in terms of coming up with the proper splint design for that. But let's backtrack a minute, because I just don't assume you give everybody who's symptomatic splints, right? So when someone comes in with a symptomatic joint, you talked about this with that young girl.
Yes.
Your protocol with that.
Yeah, well, and that's something I want to encourage your listeners, because a lot of these symptomatic patients coming in can be treated very conservatively. Do not just start throwing splints at them. Do not just start taking Alginets on them. I mean, I try to really push the soft diet and a Medrol dose pack as the first line of defense. I mean, there's so many people that come in with inflamed joints for whatever reason. Who knows? I mean, they could have, that example I showed, she yawned, could be a number of other things. It could be stressed from work, could be stressed from
COVID,
you break up in a marriage. Who knows? I mean, kids, you got a 2-year-old, it's, whatever. But something's causing inflammation in that joint space. But encouraging a soft diet and encouraging maybe doing a Medrol dose pack, cut down on inflammation, can do wonders for these patients. I just don't know how many people I've treated to this day, including spouses of dentists that have sent to me that had issues going on, and we've done very conservative stuff. And in that soft diet, I know that you might know the whole salad thing. Cannot eat salads. So,
no, that was my big takeaway.
Yeah. So, I mean, that's a no-no. I mean, leafy foods, you have to bite and shear. They get worse. So I think I put my soft diet protocol on the board when we did it, and it's not all comprehensive. People need to add to it. They need to, add more stuff, because a lot of times we add routinely to it. I'll ask my patients, what did you eat? We'll add that to the list. So hopefully we can work together to develop a more comprehensive list, but still, once it's amazing, once a patient is aware of an issue, they are so much better with it. Once they have an awareness that eating a bagel is a bad thing, man, they do better. They quit eating bagels.
Mm-hmm. So it makes so much sense. But I think doing that, the salad thing to me was like mind blowing, because I never thought to tell someone not to eat salad. But when you are, munching on a salad, you're really going at it, which is overworking the muscles, and that's causing the problem. I think another beautiful thing about just treading lightly with it in terms of getting the inflammation and the soft diet down with the Medrol dose pack and whatnot is you're allowing for the body to go back to its original state prior to that accident or incident, right? So then at that point, you may see them 2 weeks later, and then you can really do an assessment of maybe why did this happen? because you can go back in time and you can say, okay, it was that interference on that second molar that was causing that slide there. And that's why it happened that way. But it's really hard to gauge that when you're shoving, a splint in the mouth right away. So,
these joint conditions are multifactorial. I mean, there's so many things that contribute to what may have caused that joint to be damaged. Could have been trauma, could have been airway issues, could have been lots of things. So there's so many things that play a role. So I don't try to identify exactly what it is. I want to treat, I want to make sure I'm treating it properly. I'm going to investigate as much as I can to identify it, but we may not always land on one specific thing that did it.
mm-hmm.
So I just don't want your listeners to be discouraged. They go, I cannot figure out what it is, but just investigate as much as they can. A patient comes into your practice tomorrow and they can only open 10 millimeters. The last thing you want to do is try to take alginate on that patient.
You're not going to fit anything in there, right?
Yeah. You tell them about a soft diet, you put them on a Medrol dose pack, and you see them in 2 weeks. And you'll be shocked. They'll come back and they can open now 35 millimeters. Now you can start to investigate more of what's happening there.
No, that's brilliant. I think one more thing I really liked was your discussion with Bill about equilibration and how 3 or more teeth, when you're doing a bridge or something, let's say just on the right side, a quadrant, you will prep those teeth and then equilibrate the other side, because those, what I would understand, would probably be the ones that are causing the interference or the damage, because that's why you're redoing them, and then build those teeth that you prepped into the new bite that is established on the other side. That makes so much sense to me. I love that.
And it's such a simple equilibration at that point.
Yeah, no doubt, right?
You eliminated half the mouth. So and your listeners should be encouraged of how predictable an equilibration can be. Equilibrations aren't exactly fun, I promise. I mean, I don't get super giddy about seeing an equilibration on the schedule. I mean, it's not as fun as prepping veneers and seeing things like that, but as Bill called it, the cool stuff, it's not the cool stuff, but but you have to learn how to do it. It has to be a tool in your toolbox. And also, too many times, I feel like some younger dentists may want to leap into full mouth reconstruction, big veneer cases, all that stuff, and fail to learn the fundamentals of doing like a good class 2 composite, something like that. Because guess what? That's what I'm doing. I'm doing class 2 composites. I'm doing single unit crowns. You've got to know how to do a good single unit crown, a good class 2 composite, because that's what pays the bills. And I would love to say that I'm doing cool stuff all the time, but I'm not. I mean, it's just not reality.
That's my takeaway from all these guests, is that most people say that 90% of my practice is based on just bread and butter dentistry, and everything else that comes on top of that is really just an extra bonus. But do you have any pearls or takeaways for doing a class 2 composite?
I do. I actually studied this particular topic. I presented it at the Restorative Academy.
Okay.
And it's related to using sectional matrices, because that's the best really solution that we have at the time to do a good class 2 composite. Encourage your listeners a couple things. They always have to use a wedge. You cannot skip the wedge, because sometimes what will happen is they'll look in there, they'll put the band in place, they'll put the ring in place, and then they'll look in there and they'll say, it looks like it's sealed. It's never sealed. So you got to use a wedge 100% of the time.
Yep.
Getting excellent isolation, because you get contamination. If you're using a rubber dam, if you're using cotton rolls, or whatever you're using, just don't let it get contaminated down in, especially in that box space. That's a critical area. The other thing I would encourage them to do is throw away your rings probably about every 6 months.
Sure.
Because those rings, and I did the study, after 100 cycles, you lose about 20% of the compressive force on all the rings. Every ring on the market. So, there's some are a little better than others, got a little better features and stuff like that. But just because what we do is we don't throw away those rings until there's so much old nasty composite on it, we can't even tell it's a ring.
Sure.
Then we throw it away. We have no idea how many times we've used these rings. We don't. We have no way of monitoring it. So I would suggest pick a time on your schedule. Like you buy a new set of rings, and then X months later, you chunk them, and then you buy a new set. And they're $100 a piece, right? They are. So they're not cheap. But think about what it costs you when you prep that tube and you go to do that class 2 composite and you finish it and you go to floss and you got that big open contact.
It's the worst.
Dang, I cut that baby back out and start all over. It's just not fun. So I would encourage listeners to do that too.
Those are brilliant little tips. I think that I couldn't agree more. I have an intern at my office, and I'm constantly showing him, like, oh, if you see that, sometimes even when you use a wedge, sometimes the matrix doesn't get quite sealed over there, and you can kind of see the color pink or whatever wedge you're using. I take it out, I push it down, and it's so annoying, but at the same point, it's going to save you time when you're finishing it, and also the margin's going to be sealed over nicely. So you got to take the time to get the right position of that band, get the wedge, get in there, and then the ring separated. So
3 things you need to tell your things. They got to get contacts, contour, and they got to get a proper seal. So
sure.
All those things to get a good class 2 composite.
Okay. What about if you have like an MOD? Do you have any advice about kind of getting a nice contact there?
Whenever you have 2, like an MOD?
Yeah, MOD or like an MO and DO butting up against each other.
Well, I typically do 1 at a time. And if you try to do them both together, and I have, it never works.
I haven't had success, yeah.
I'm just not as skilled. There's probably dentists out there that can do it that are a whole lot better skilled than me. Probably Bill can do that. I don't know.
Of course. Magic wand.
I have to do it 1 at a time.
Sure.
And so that's just part of the deal, man. You just got to do it. I know it's pain, but you got to do it.
No, I'd agree. And then like an MOD with a matrix band?
MOD, I'm gonna do 1 side at a time.
Okay, and then you just move it over. Yep.
Yeah.
And you do the same stuff I do. This is good. It makes me feel like I'm doing something right here. How about crown preps, like a single unit? Is there something that you would advise about in terms of?
Well, I mean, I think we all go on this journey from time to time to get the perfect crown prep. I mean, I think all of us go down this path. And some dentist that Brian Schroeder did, a good friend of Bill and I, he's like a master. His look like they've been milled. It's really not fair. These people who have these hands and skills that prep teeth and it just looks like it's milled, mine don't look that perfect. I do try to make them as perfect as possible, but they just don't. The main thing is you got to make sure that margin is smooth. Now, the only thing I will do is I always go back with no water and just refine that margin, make sure it's perfectly smooth as I can get it. And we got to get a good impression. And if you're scanning, you've got to see those margins. So whether you're scanning or again, you just got to read the margins. You got to have a smooth margin. You got to be able to read it. And if and scanning, you said you're going to get a scanner soon, and scanners will really help you see that, man, I don't prep that good, you know?
That's right. Ego buster. I love that. Occlusal reduction. I know that's a big one for crown preps. Is there anything that you do in terms of knowing that you've made enough occlusal reduction?
Crown preps always start with one particular burr. I wish I knew the number, which I may get it for your listeners later, but it's a straight shaft. It's a green stripe, straight shaft. I bet the diameter of this thing is maybe a millimeter and a half, and it's got a flat end on it. And the reason I like it versus anything tapered, this is what I start my preps with. I don't finish with this. I start it with this. And I use it to cut the bulk of what I need to cut because it cuts really fast and it'll take away the bulk of what I'm trying to do. And I'd say it's about a millimeter or so in diameter, maybe, and I'll use it to do my depth cuts almost in my occlusal reduction to give me an indicator I've cut a millimeter and a half down. So that's one little deal that I do when I'm doing occlusal reduction.
I think that's great. I think depth cuts are so important, and I remember Kirk had somebody on who's a lab guy, and I think that's one thing that was the number one lab issue was, not enough occlusal reduction. I think we all egotistically think we can know how much we need to reduce, but if you're doing a depth cut through it, it takes away the guesswork.
And also going back to that second molar, they've got to seat those condyles because
that's what I was going to lead into, right?
They may go in there thinking they've cut enough away, and then when you seat the condyles, you realize I got no more room.
Yeah.
I'm going to cut another 2 millimeters away.
Amazing, right? You do your depth cut and then you have them bite down. The teeth are touching still. Why did that happen is because, like you said, the condyle is seating up there appropriately. So that's really quite brilliant there as well. So interproximal contacts and adjacent teeth, do you do anything in terms of getting a nice contact in the crown?
No, I mean, I don't do anything special probably that, Bill, you got any tips on that?
Yeah, Bill, you've been silent over there.
Well, I think where Kevin's going with this is not only do you pay attention to the tooth you're prepping, but you pay attention to the contacts on the mesial and distal. And a lot of times their shape isn't good. Mm-hmm. And so I do pay attention to the interproximal contacts adjacent. And the other is the opposing cusp. And I think, especially the farther back you go on the mouth, it's pretty common for me to reshape the opposing cusp also. So I'm usually prepping 4 teeth instead of 1 commonly before I'm done.
Mm-hmm. That's what I was kind of getting at. I think when I first got out, we're so paranoid about touching the adjacent teeth in dentistry because in dental school you got a failure if you did. But I realized that I was having these pinpoint contacts or whatever it may be instead of a broad contact because the adjacent tooth had a point to it. So it just kind of smoothing that back sometimes makes a world of a difference too. So, well, geez, it's already 9 o'clock. So we breezed through this, Bo. I've really appreciated this discussion. Bill, do you have any final thoughts or anything that you would have to say?
I never have anything to add after Bo talks. I just sit and listen and learn. I mean, and seriously, I think he has got more common sense when it comes to occlusion than anybody I know. I always love listening to him, and I've heard him many times. So I'm not patronizing you, my friend. I think it's the truth. I really enjoyed tonight also.
Well, that's humbling. That's humbling coming from the master, So I tell you, the other beautiful thing about this practice of dentistry is the friendships you make. I mean, that's the really special thing.
Here.
I mean, like I said earlier, the teeth we fix will one day be in a box, but these friendships we have, they're going to last for generations.
That's the best quote you've said all night. How can people get in touch with you or see you lecture or whatever you may be doing?
Well, my email address is drbruce@upstatesmiles.com. So they're more than welcome to email me with questions. And I have a lot of people that do send me emails about a case or questions or whatever. And I'm happy to get to that. I usually try to get to those about once a week. I'll go through them and try to answer those questions. And as far as lectures, I do a lot of Seattle study clubs. So I'm in those programs. I will be at the Hinman if we have the Hinman next year. I'm going to be a featured speaker at the Hinman talking on occlusion and some aesthetic treatment planning and different things like that. So I'll be around if somebody needs to find me.
That's great. No, I'm excited for this friendship that we just established within the last couple minutes here to continue to keep going on as time moves forward. But the same thing with you, Bill. You're linked with me now forever. So I've thoroughly enjoyed this hour. This has been such a fun topic, and I appreciate the common sense, like you said. I think there's beauty behind the fact that you said you're a slow learner. So you had to learn in a different way that it allows you to teach in a different manner too, which is the most beneficial thing that most people can take away from that, which I appreciate the vulnerability and the authenticity to it all too. So next week, we're kind of doing something different. So Kirk and I are going to be on tomorrow recording a podcast as a summary of all 8 episodes is what I've learned in the last 2 months. So we're going to release that on both his podcast and also our channel. So next week, we're going to take a little break, but we're going to try a couple different things here and there, but we'll see what we do and we'll keep going after that. So stay tuned, everyone. We'll send out a lot of emails and whatnot, but again, Bo, thank you for being on here. I really, genuinely enjoyed this hour.
You're doing an exceptional job with this program. It's really fantastic.
So,
and Bill, thanks for being my co-host in the background there. Good luck with your COVID test tomorrow. So, all right. Thanks.
Always a pleasure, you guys. Good to see both of you. Thanks so much. Have a good evening.
Yeah, you too. Thanks, guys.